Right. Good evening, everyone, respected guests and dear colleagues. We are overjoyed to welcome you all to the 7th masterclass of ASGI Hospital. I would take this opportunity to welcome you all here. As we know, this is the 7th masterclass. Previously, we have completed 6 masterclasses regarding various retinal and anterior segment topics. Today's topic is the art of pneumatic retinopexy. And we are delighted and overjoyed to introduce our speaker, Dr. Rajeev Muni. Dr. Rajeev Muni is a staff retina surgeon at St. Michael's Hospital, the Hospital for Sick Children and Kensington Eye Institute in Toronto, Canada, and is the Vice Chair for Clinical Research in Departments of Ophthalmology and Vision Sciences, University of Toronto. Dr. Muni completed his medical degree at McMaster's University, followed by residency in ophthalmology and fellowship in vitreoretinal surgery at the University of Toronto. He was awarded the Detweiler Fellowship from the Royal College of Physicians and Surgeons of Canada for advanced training in pediatric retinal surgeries at the University of Southern California. Dr. Muni went on to complete a master's degree in clinical epidemiology at the Harvard School of Public Health. Dr. Muni has won several awards for his research and teaching, including the 2018 Eye Physician and Surgeon of Ontario Innovator of the Year Award. He has a professional association with the American Society of Retina Specialists, the American Academy of Ophthalmology, and the Canadian Ophthalmological Society and Retina Society. Dr. Muni has over 60 publications in peer-reviewed journals. So, Dr. Rajeev Muni is also a recipient of 2018 Innovators Award, as I've already discussed, for his work in recognition of the groundbreaking work in randomized trial comparing pneumatic retinopexy versus vitrectomy in management of primary rheumatic retinal detachment. So it would be a delight to listen to Dr. Muni's thoughts on pneumatic retinopexy. I am also delighted to introduce our panelists. Our esteemed panelists include Dr. Satyen Deka. Dr. Deka completed his MS ophthalmology from Assam Medical College in 1996, became a diploma of National Board in 2004. He had done a general ophthalmology fellowship at Shankar Deva Netralaya Guwahati in 1997. Sir completed his vitreoretinal and research fellowship from Sankara Netralaya, Chennai from 1998 to 2000. He received training in vitreoretinal diseases and cataract at Newfields Eye Hospital, London, England, 2004. Training in Orbis International Ophthalmology Program in 2013. He successfully participated in ICH, GCP workshop and clinical research in 2014. He has completed his training at Johns Hopkins University, Baltimore, USA, Wilmer Eye Institute Retina Division in January and February of 2016. Our next panelist, Dr. Sourav Sir. Sir, after completing his Masters of Surgery in Ophthalmology from Karnataka University, Dr. Sinha did his fellowship in vitreoretina at the prestigious Sankara Netralaya, Chennai. Sir has been judged the best outgoing fellow for his time there. Previously, Sir was also a medical director of Shankar Netralaya, Kolkata. During his decade-long association with Shankar Netralaya, Dr. Sinha has always taken a keen interest in passing on his knowledge to others and has personally trained many fellows in vitreoretinal surgeries, both from India and abroad. Sir has been an academic and is also a major contributor to various national and international journals. He has published many articles in the field of retina and is a regular presenter at national and international conferences. We welcome you, sir. The next panelist today is Dr. Rohan Chawla. Sir is the additional professor at Dr. Rajeev Muni Center for Ophthalmic Sciences at AIIMS, New Delhi. Sir has completed his MBBS from Maulana Azad Medical College, New Delhi. Did his post-graduation at RP Center and also did his training in vitreoretina at RP Center, AIIMS, New Delhi. Sir is also a fellow of Royal College of Surgeons of Glasgow. Sir has many awards and accomplishments to his name. He's a distinction in ophthalmology in MBBS, Lieutenant Governor's All-Rounder Trophy in MBBS. He has more than 250 PubMed index publications. He's editor of the book on ocular tuberculosis. He's a reviewer of articles of international journals such as Ophthalmic Surgery, Lasers and Imaging, and American Journal of Ophthalmology and Indian Journal of Ophthalmology. Sir is a teacher and a mentor to a lot of young ophthalmologists at RP Center. He's one of the go-to surgeons for all surgery and medical related queries. I welcome you, sir. Thank you. Also, I would like to update that the next masterclass would be scheduled on the 30th of Jan 2023 at 9 p.m. The speaker would be Dr. Pramod Venge sir, and the workshop would be on diabetic vitrectomy, all you need to know. Thank you so much. Now, I would like to invite Dr. Muni to start his address, please. Thank you so much.
Okay, I'm just trying to share the screen. If you could stop screen share.
Certain Nikas, please answer your screen.
Okay, well, thank you very much for the kind invitation. I'm very excited to speak today to you about pneumatic retinopexy, which is one of my favorite topics. I have a fond, memories of my time in India in high school, as I was mentioning earlier. So thank you for involving me in this program. So this is a patient following vitrectomy for rhegmatogenous retinal detachment repair. And we see patients like this day in and day out. Visual acuity is 20/25. And we would all agree that this patient has had a successful outcome based on our metrics that we commonly use. But we also know that patients like this complain of symptoms such as metamorphopsia and anisoconia. And we started looking at these outcomes and finding that patients did have significant vertical and horizontal metamorphopsia and anisoconia. So if a patient's complaining of these symptoms, can we still really call it a true success? And if we look in the literature, we see a large proportion of our patients after retinal detachment repair complain of these types of symptoms. And we all know how, patients come in and they're complaining about these things, but they're 20/25, and we're thinking you're just lucky that you have some vision. And, we stopped kind of evolving a little bit in terms of how we treat retinal detachments. So in 2012, we started the PIVOT trial, a randomized controlled trial comparing pneumatic retinopexy versus pars plana vitrectomy. We used to do a lot of pneumatics at that time, but we really wanted to know what was actually better for patients. And so we looked at ETDRS visual acuity over time, and the pneumatic group was better by 10 letters at 3 and 6 months, and by 5 letters at 12 months. So at every time point, pneumatic retinopexy was better. But what was most interesting was that vertical metamorphopsia was significantly less in the pneumatic group. And this is what kind of lit the light bulb for us, because we realized that maybe there's a difference in how the retina is being reattached, and perhaps we can account for these differences that we might be observing in metamorphopsia and anisoconia. So a colleague of ours, Dr. Vas Sada, who I'm sure you've all heard of at Doheny Eye Institute, collaborated with us, and he basically took all the imaging from the PIVOT trial, all the OCTs, which we took at multiple time points, and we looked at the risk of ellipsoid zone and external limiting membrane discontinuity in vitrectomy versus pneumatic, and we found that patients in the pneumatic group had significantly less abnormalities of the outer retinal bands. And if you look here, you see examples of ellipsoid zone loss, and this was much more common in vitrectomy versus pneumatic, again strengthening our impression that patients undergoing pneumatic retinopexy may have a better reattachment of the retina compared to vitrectomy. So let's look at our patient who has 20/25 vision but has significant vertical and horizontal metamorphopsia and anisoconia. This is another outcome, which if we look at the fundus autofluorescence, we see these hyper-autofluorescent lines indicating the location of the retinal vessel before the retinal detachment compared to where it is now. And we see that the vessel here has shifted from its original position. We look at a patient with pneumatic retinopexy, and we started to notice that we weren't finding as much of these cases of retinal displacement. And so we carried out a multi-center retrospective study with 3 centers in the UK and Canada, and we found that the risk of retinal displacement was very low in the pneumatic group, 7% versus half of the patients in the vitrectomy group. And we call this a low integrity retinal attachment. We carried out then a prospective study, again, multi-center, and found similar results. But this was only in MAC-off cases in the second study, so that's why the risk is a little higher. But again, you see that vitrectomy has a 50% risk versus 14% in the pneumatic group. So I've shown you 2 outcomes, ellipsoid zone and ELM discontinuity and retinal displacement, both of which are worse in vitrectomy versus pneumatic retinopexy. Furthermore, if you look at in the ALIGN study, the second prospective study, anisoconia was significantly worse in the vitrectomy group versus the pneumatic group, and also in patients with retinal displacement versus without. So why does this happen? Well, we know that retinal displacement is a stretching of the retina. If you stretch the cone mosaic, things look different for patients. It's as simple as that. What is the mechanism of retinal displacement? We know that there's always fluid left behind at the end of surgery, and this fluid gets displaced by the buoyant force of the large gas bubble with changes in head position, and forcing this fluid under the thin elastic retina will lead to a stretching of the retina and retinal displacement that we all see. I want to show you this case of a supratemporal retinal detachment, macula off. This is a patient that many people would just do a simple vitrectomy, and you would see in panel B here that the autofluorescence looks fine. Maybe there's a little bit of hyper autofluorescent lines, maybe a little bit of retinal displacement. So you would say, so what? You know, if the retina has moved a little bit, you know, my patients aren't complaining, they're still seeing 20/25. But I want you to look at panel D here. So what was unique about this case is that we had the fundus autofluorescence of this eye before it ever even developed a retinal detachment. And what we did is we superimposed the FAF before the detachment ever occurred and after the repair. And if you look at panel D, you see that every single temporal retinal vessel has been shifted. Every vessel has been displaced in the region of the retinal detachment. And it highlights how with vitrectomy, although you're getting anatomic reattachment, you're putting the retina in the wrong position. Okay, and this is the biggest concept, which I think has changed people's perception for pneumatic retinopexy, because before the argument was, well, the success rate is higher with vitrectomy. But if we tell you that half of the time, maybe even all of the time, the retina is in the wrong position, people start to feel, well, maybe we should find a different way of thinking about how to put the retina back in place. So how do we assess the integrity of retinal reattachment? First of all, I would recommend you get fundus autofluorescence at 3 months postoperatively for all your patients. And we understand that using the fundus autofluorescence is very helpful to indicate the integrity of retinal attachment. We know that retinal displacement is due to this forced iatrogenic movement of fluid. And the more we learn, we realize that pushing fluid, forcing fluid is not beneficial to the retina and retinal reattachment. And this has real outcomes for patients, including seeing objects as smaller and pinched in. If you ask your patients after retinal detachment repair, many will say, you know, the doctor, your head looks smaller and pinched in, and this is related to retinal displacement. There's also other outcomes we've looked at, like outer retinal folds, which are also more prevalent after vitrectomy versus pneumatic. We've developed a on-fast technique with a customized segmentation to look at this. And we know that the risk is greater in vitrectomy versus pneumatic, and also that patients who have these outer retinal folds tend to have worse vision, 10 ETDRS letters worse vision. So to summarize this kind of academic portion, you know, many great surgeons over the last century have done amazing things to find ways to reattach the retina when we couldn't reattach the retina before. But this next era is going to be different. We have to understand that anatomic reattachment is a very crude measure of success. It's not equal to success. And we have to think back to putting the wallpaper back on, and we want to do it without folds, without crinkles in the wallpaper, without stretching up the wallpaper. Pneumatic retinopexy, by closing the retinal break, allows the retinal pigment epithelium to reattach the retina. There's no drainage, internal forced drainage. There's no large gas tamponade squeezing the retina in place. And we feel that this is what will lead to better outcomes for patients, because you'll allow the RPE pump to reattach the retina, much like a segmental scleral buckle with non-drainage. You know, minimally invasive buckle techniques have the same principle. So I'm going to transition now into the practical aspect that we can discuss. So when pneumatics came out in the 70s, Dominguez started doing it first in Spain. And then it was popularized by Hilton and Grizzard. And Paul Turnamby, who I got to speak to quite a bit in the last, maybe prior to his passing in the last 5 years, started the pneumatic retinopexy trial, and he looked at standard criteria. So that was when you had retinal breaks within 1 clock hour with no other pathology. But we wanted to expand the criteria because we felt that this was only applicable to a small proportion of patients. So in the PIVOT trial, we included patients who had breaks within 1 clock hour in detached retina, but they could have any pathology in attached retina, even a giant retinal tear, anything in attached retina that we could laser before the gas bubble was eligible. These are cases of extended criteria that were not included in the PIVOT trial, but that we do pneumatics for. Patients who have slightly inferior breaks, multiple breaks that we can sequentially tamponade, breaks in different quadrants, and all of this pathology in attached retina, we're going to laser before the gas bubble injection. So I want to show you my pneumatic retinopexy technique.
A very old book.
So the first step is you put topical anesthetic, then use a subconjunctival lidocaine injection in the quadrant you're going to inject the gas. I try to not inject in quadrants where there's large gaping breaks. Then for the procedure, the AC tap is really the most critical part. So you see I'm injecting a 30 gauge needle on a TB syringe, and I'm going inferiorly over iris, and I'm putting very strong counter pressure with the plunger. This pushes not only aqueous, but liquefied vitreous out into the needle. And sometimes I can get 0.5, 0.6. Then we mark and we inject 4 millimeters back with a 3 cc syringe with the gas and a 30 gauge needle. You put the needle halfway in and then pull back so the tip is barely in. Make sure you keep holding the plunger down so the gas doesn't reflux, and cover the needle tract with a Q-tip. Here you can see I'm examining. I never check the pressure after a pneumatic. I'm just looking at the perfusion at the central retinal artery. If it's occluded, I'll do a retap. If it's pulsatile, you can wait a little bit and then do a retap if necessary. And if it's completely patent, then you don't have to retap. And when the central retinal artery is perfused, that's when they can be discharged. So you don't need to recheck the IOP or anything like that. This is that patient. You see a single superior break, inferior lattice. Here you see at 2 hours, the retinal detachment is much better. We lasered the pathology. Aditya did this one, so you can see all the fish eggs that he got, and then he wasn't allowed to do them for another day or two. And then we injected the gas bubble. Then you see at 1 day, the retina is mostly attached. At 1 week, you see that the retina is attached, there's the gas bubbles getting smaller, and at 2 weeks, retina is fully attached and break is lasered. Now, what gases should we use? We very much prefer SF6 gas because it expands very quickly. Within 36 hours, you reach maximal size. With C3F8, it takes 4 days to know if the retinal, if the reattachment is happening or not. You really can't assess until it reaches its full size and the patient's positioning. So who wants to wait 4 to 5 days to know if it's working? What we do is we use SF6. Usually by 1 to 2 days, we know, is it getting better? Is it not getting better? Sometimes we add a second bubble of SF6. So you get the same benefit of a large bubble that you would get with C3F8, but we do it sequential injections so that we also get a very fast expansion. The other problem with C3F8 is you have gas inside for 38 days. And you can see that with 38 days, that's a long period for there to be gas in the vitreous cavity. So with SF6, it goes away in 12 days, which is perfect for pneumatics. It's in and it's out, and that's how we want it for pneumatic retinopexy. So the injection technique, again, put the needle so it's halfway in and then pull back so only the tip is barely in, and then you inject the gas, not too fast, not too slow, into an ever-expanding bubble. And this will allow you to get one large bubble. And you see some of the cases even posted today of a large gaping break. You don't want to get fish eggs because then they can go through the retinal break. But when you have one large bubble, it's very unlikely to get subretinal gas. I would say 1 out of 400 or 500 cases where we get subretinal gas that we can't remove, that we have to take them to the OR. It's very rare if you do the technique properly. Then we like to do steamrolling, and this is an area of debate. We're rethinking, is it really necessary or not necessary? So I'm open to, different opinions on this. Like, our preference is to do steamrolling. I think the fellows, you guys like steamrolling too, because you see that the retina is attached much faster. But then again, it goes back to our thing: do we want to force it to be attached or not? So I think that we like to. Right now, we're doing steamrolling 6 hours for MAC off, 4 hours for MAC on, and then we raise their head slowly 30 degrees every hour. I highly recommend you use topical steroids for the first week. That will quiet the eye down. It'll make your indirect laser much better. I'm very strict with positioning, but you don't have to be. Some people do it for 5 days. I say do it until the bubble is gone and keep your head in the position. As if the bubble's there, you might as well use it. But I say, you can't go for walks. You can't go to the grocery store. You have to be doing this positioning all the time, except when you're eating and going to the washroom. And sometimes I even make them show me the positioning. And when a pneumatic's not working, I'll say, oh, so, can you show me, how are you positioning? They'll say, okay, I'm positioning like this. I say, okay, how many hours in 24 hours are you doing it? And they'll say, oh, well, all the time when I'm sleeping. But I said, oh, what about the rest of the time? They say, oh, I didn't know it. You had to do it all the day. So you have to really go over these types of things, and you'll hear people's funny explanations of what they thought they heard you say. But so that's why I like seeing patients on day one, because I can check, make sure it's improving and that they understand the instructions. And if they position, it's almost always pneumatics work. So, when it doesn't work, a lot of times it can be compliance related. So again, when you have a break in attached retina or any pathology, vitreoretinal tags or anything, make sure that you're treating that first and then injecting gas. So let's get into some cases. 15-year-old boy, shallow MAC split detachment. Dialysis superiorly at 10 o'clock. I love doing pneumatics in pediatric cases. They have very strong RPE pumps. They have mothers who will watch them. They will make sure they don't move and who want there to be a success. And this is the best thing for children. And so that they usually work very well and very quickly. I do cryo in children because you might lose their cooperation on the second day. So I've done cryo. I know I have something in place, even if they don't let me do the laser, but I always supplement the laser because I don't fully trust cryo if patients stop positioning. This is a pseudophakic detachment, inferior break, temporal break, inferior bullous detachment. When you see an inferior bullous detachment, you're always thinking superior break or temporal break. And these are great cases for pneumatic retinopexy. You tamponade the break and the inferior fluid will go away very nicely, as you can see here, in a few days, fully attached. This is a patient, high myope, has one of these posterior horseshoe tears here nasally. We injected the gas bubble, and a few hours later, you see a significant improvement. The next day, it's fully attached. The bubble subsequently went away. This is a patient with choroidal detachment and a superior break. These are great for pneumatic retinopexy. Who wants to go in and do a vitrectomy, have issues with your infusion line? Doing a buckle in the setting of choroidals is not simple. Inject a gas bubble in the quadrant where there's no choroidal. It'll solve all your problems. The choroidal will go away. You'll tamponade the break. The retina will reattach. Even if you have to do a vitrectomy later, it's much easier. Your eye is reformed now. You don't have a choroidal detachment. The fluid is less. It's much simpler to do surgery. So here you can see over time the choroidal resolved and the retina reattached here. And you can see a week later, it's fully attached. Break is lasered, the choroidal is gone. What about large posterior breaks? So this was a 78-year-old male, superior temporal radial break, okay? So we put in a gas bubble and the next day it's looking worse. The whole retina is detached, it's bullous, like should we give up, book in the OR? But no, you realize that it's all about closing the break. So you don't have to panic on day one if it's not going well. You have to rethink, okay, well, if I look at this, it's still very bullous fluid. There's no inferior break. So it has to be coming from that same superior radial break. And probably the patient, if he's upright, it's not covering the bottom part of the break. And if he's face down, maybe it's not covering the top of the break. So what we did is we put a second bubble in on day one and positioned the same way, but said, okay, maybe bend forward a little bit, 45 degrees, so you cover the whole break. And the next day was fully attached, and we were able to laser that break. And you actually see it's not that peripheral. Breaks look more, not that posterior. Breaks look much more posterior when you have a bullous detachment. Here's a patient, 23-year-old female, large dialysis infratemporally. Again, young patient, very good RPE pump. Just put in a bubble. Even the vitreous sometimes will plug the brake itself, just like in a buckle situation. And here you can see the next day it was almost fully attached, and we started to laser the brake. And it was, this was one of your first ones, I think.
This was
Alvaro, but
Yeah.
in your research
Yes,
fellowship.
research
Yeah. So Aditya imaged this patient almost every day and was able to monitor the resolution of fluid. So what about some other examples? So actually, did we skip one video? Let me just see. Okay, no. So I'm going to show you some videos now, some more videos. So this is a patient who had a pediatric detachment. Patient came from Australia, had a sutured IOL, a sutured lens in place, had Marfan syndrome, had a nasal and inferior detachment. We found a nasal break. The macula was attached. So with kids, you got to get them to buy into the whole process, So he said, if you play my music, I can chill out and you can do this in the clinic. So this is my me and my research, my pediatric retina fellow doing this case. So again, I told you in kids, I like to do cryopexy because I know I've treated the break, even if they stop cooperating after the first day. If for some reason they had a lot of pain and they don't trust you anymore, you know that you've gotten the cryoing. So we're doing the cryo just in the clinic with subconjunctival anesthesia. So it's very simple, and patients tolerate it quite well, because you usually only need 1 or 2 freezes. Again, here, a big AC tap, I'm pushing very firmly with the plunger. I'm indenting the whole eye, and I'm doming up the cornea so that the cornea stays over the needle and I'm not incarcerating the iris. Always pull the needle out very slowly. And then we inject the gas, and here you're going to see I'm going to put the needle in halfway in, okay, and then I'm going to go halfway, then I pull back so the tip is barely in, and then I inject the gas and hold the plunger as you're taking it out. And you can see that, and then again, I'm not checking the IOP, I'm just looking for the perfusion of the optic nerve. I'm very carefully in explaining the position to the child, to the mother, everyone, so that they fully understand, what's involved in the positioning and how important it is.
4 hours, head down, rest of the day, sorry, on the right side. Got it.
So this is day 2, retina is attached, vision has improved. You can see the beautiful OCT.
Can you tell us your experience with the procedure? Well, first I was a bit scared.
So he's just saying he was scared at first, but then when he got home, it was fine. He was lying on his side, and his mother was helping him a lot. He said it hurt a little bit, but it wasn't too bad.
So how are you coping with the positioning at home? It's fun because
Kids love positioning. They can just stay on their device and play video games all day. And so if I told my kids they had to position, I think they would be very happy about it.
Feel about your recovery?
Yeah, after the first day, it feels like it doesn't hurt as much. Doesn't really hurt. Yesterday, I had to build it around there. Now I the color fitting showers.
So this is the mother's perspective.
Kai had pneumatic done 2 days ago. So how do you feel about that?
It's scary. I said we've had a few different procedures in the last couple of months, so I was a bit nervous, but it worked out so well for Kai that I have nothing but good things to say about it. Kai felt confident.
So they basically had it's not as, I think some people think that the positioning is so difficult, like kids won't do it, but it's really not that complicated. And I think that the main thing is they have to know that the physician believes it's going to work and they will buy in. So this is another case of a GRT 10-5, very large detachment, large break. GRTs, everyone thinks that they'll never work with pneumatic, but it's actually the opposite. When you have such a large break and you put a gas bubble in, where's all the fluid going to go? It's going to come out right through the break, and it attaches very nicely. So in our series in Toronto, about 2/3 of all GRT cases were attached with pneumatic retinopexy. 1/3 had to go to the OR. But even if it goes to the OR, it's much easier for me because usually I have most of the retina attached. If it's not fully attached, it might be the inferior horn or something. And here you can see the patient was very compliant. And so now instead of a big surgery with PFCL and direct PFCL silicone exchange and no slippage, you can just do a small segmental or a very simple procedure. It turns a complex detachment into a simple one, even if it doesn't work. And patients, again, children, very compliant a lot of the time. So you have to pick and choose your patient carefully, but it can be a very nice procedure. Here you can see the extent of the GRT peripherally. You see how we almost have 5 rows of laser that we've applied all around. And I just saw this patient yesterday, 14-month follow-up, fully attached, no buckle, no silicone oil, no vitrectomy, just 1.6 SF6 gas bubble and some laser treatment. So what about when things go wrong? Sometimes you can get fish eggs. It's important to, when you get fish eggs, you can put patients face down for 1 day, and that will allow the bubbles to coalesce. And again, it's technique related to, you want to avoid getting them in the first place. If you do get them, usually you can depress them out. Persistent fluid, this is the biggest thing I think when you're learning, like you get displaced fluid and you think it's failing, but it's not failing. It's just this fluid gets shifted by the buoyant force of the bubble, and you'll have residual inferior fluid, and you just have to be patient. It'll usually go away over time. Sometimes in these chronic detachments, it can even take months to go away. But usually if you steamroll, you've moved it away from the fovea. And so it's basically not an issue, and it just takes time to go away. So what about when pneumatics fail? What are some of the keys when you're doing vitrectomy for failed pneumatics? It's very, very important in phakic patients. You tell them you have to stay face down until the moment I see you in the operating room, because if they're lying on their back in the pre-op area at home before and relaxing, what's going to happen is you're going to get a cataract, forming a gas cataract from the bubble. And then you start doing your vitrectomy, within 10-15 minutes, you'll lose your view. So I'm very carefully telling the patient to maintain face down. And when I start the vitrectomy, I remove the gas bubble very early on so that I clear the lens from the gas. Now, in the event you get this gas cataract, there's actually a technique we're just trying to work on now. But if you actually go to air, paradoxically, the gas cataract will go away after some time. We're still testing how long you need to be under air, but I think if you're under air with a significant pressure, it'll basically somehow change the dynamics of the physiology of the lens. And this is not a permanent cataract, it's gone by the next day. So it's just a matter of managing the situation. Now, what are some of the common myths? People are going to tell you, oh, pneumatic retinopexy is a bad procedure because you're not relieving the traction, but we never relieve the traction with horseshoe tears, and they don't detach. Think about pneumatic as going back in time to when you have the retinal break and you're applying laser to the retinal break. And we know that always works almost all the time. Some people think it's not a long-term solution. They're going to come back detached in 4 months. We know that it's a very durable treatment. Only 1 to 2% of pneumatics fail after the 3-month mark, 2 to 3% of vitrectomies in our pivot trial results. People think that if they fail, you're going to have worse outcomes. But in the randomized trials, both Paul Ternemi's pneumatic retinopexy trial and our pivot trial, there was no increased risk of PVR. There was no these disasters that people talk about. It's as long as you're following the patient very carefully. I think that's the key. If you put in a bubble and you say it's attached on day 1, you laser and say come back in 2 weeks, and you're in vacation in the Maldives, they're going to come back with PVR for sure at times. So I monitor them. I see them a couple times in the first week, 1 or 2 times in the second week. I make sure they're fully attached. All the fluid has gone away. The brakes are lasered. Then I start spacing out the follow-up. People think, oh, well, who wants to have so many visits? Well, if you look at the number of visits over the course of a year, in vitrectomy, it was 9.6 visits versus 10.8 in pneumatics. So it's about 1 visit longer over the course of the year. It's more intensive in that first week or 2, but over the course of the year, it balances out. And don't forget, all these vitrectomy patients, they have to have cataracts and other things. So everyone thinks, well, I want to do one procedure, one different things. People will say like one home run or like one and done. We don't want to do multiple procedures, but let's look at the numbers. So in the pivot trial, 81% success with pneumatic, 93 with vitrectomy. What's the difference? 12%. So if we take the number needed to treat, it's 8.3 patients. So you're going to subject 8 patients to surgery to save 1 patient from needing an extra surgery. So if you don't want to do a lot of surgery and you want to minimize surgery, it makes sense to do pneumatics. And when they're not working, go to vitrectomy right away. Not to mention, all of these patients are going to have cataract surgery in one or both eyes because of their myopia. So in conclusion, pneumatic retinopexy should be considered a first-line treatment for patients who meet criteria. And this is a treatment that can be used in old, young, phakic, pseudophakic, and all types of patients. The key is when you're learning, as you're starting out, don't be too aggressive. If it's not working, go to your buccal or your vitrectomy, and don't sit on failure. When it's failed, admit that it's failed and go to surgery quickly. This way, even if it fails, they have the same outcome had they gone to surgery from the beginning. So you never lose anything with pneumatics. And those who have a lot of experience always say that we haven't lost anything if it hasn't worked other than a few days. This is the last video I'll show you.
Du, hier vorne. Was ist dein Handwerk? Ich bin Töpfer. Ja. Und du, Arcadia? Was ist dein Handwerk? Herr, ich bin Bildhauer. Und du? Ich bin Schmied, Herr. Spartiaten! Was ist euer Handwerk? Ich habe mich Zeit an.
Thank you.
Thank you, Rajeev, for an excellent presentation. Really beautiful.
Thank you. Yeah, I'd like to, if anyone has any questions, please ask us. And if you have questions from the fellow perspective, I have my fellows here too. So if you have any questions, please tell us. Yeah.
Rajeev, I am having a full list of questions.
Okay.
Okay. So I'm going to start with the first question from Dr. Ganesh. How many patients you are seeing with the post PNR ERM when the retina is attached and you are seeing after 1 month or 6 months ERM formation is there?
Yeah, I think, ERM is an interesting thing. First of all, the risk is not greater in vitrectomy versus pneumatic. We know that. We have data that we're looking at now. It'll be published very soon. We've also done retrospective studies on this. I feel like, we're spending so much effort right now on trying to figure out how can you attach the retina to its best position as close as possible to its original position. But you do that, and then 3 months later, they get this massive ERM and their whole retina is distorted. And that's really the next, I feel like the biggest challenge that we as retinal surgeons are gonna face is figuring out should we do ILM peeling first? I feel that that's a little aggressive. Will there be some sort of medical adjuvants? So my answer is that there's no increased risk. In the randomized trial, there was no increased risk. We looked at imaging, we looked at the number of patients having surgery, people had vision loss for ERM. There was no increased risk in vitrectomy versus pneumatic. However, it's still an outstanding issue in both pneumatics and vitrectomies. We need to figure out better ways to avoid the ERM, which is really a form fruste of PVR. We're seeing like kind of a mild PVR situation, and we have to try to figure out how to improve that.
Thank you, Dr. Rajeev, for a wonderful talk. The question why I asked was because of the fact that I have done few pneumatics and I got these ERMs post-operatively, for which eventually I had to do vitrectomy for these patients.
Yeah, I think that that's a great question. And I think that there is this theoretical increased risk. People might think it's higher. The randomized trial data does not show that it's higher. There's no greater risk in one treatment versus the other. This is a epiretinal membrane is a glial proliferation. You might think, oh, removing these RPE cells will reduce the risk, but look at some of the recent data from Japan. Like people who have posterior retinotomy have a 90% risk of epiretinal membrane formation. We recently compared PFCL versus posterior retinotomy versus drainage from the break. It was much higher in the posterior retinotomy group. So I think there's a lot that we don't fully understand about why you're getting epiretinal membranes. It's not just clearing the vitreous, and our data from the randomized studies doesn't show increased risk.
Rajeev, second question is, your main aim to shift over the this PNR is displacement of the retina. Why there is a displacement of the retina when you are doing a non-drainage buccal or the attachment of the retina with the PFCL?
Okay, so displacement is one of the factors. We are very interested in this integrity concept, putting the retina back as close as possible to its original position. What does that mean? Photoreceptor discontinuity, like I showed you, that we published with Basada. Number 2, retinal displacement. Number 3, outer retinal folds. If you look at any anatomic outcome of success, other than is it attached or not, if you look at the quality, the integrity of that attachment, in everything, it's worse with vitrectomy versus pneumatic. Secondly, why do you get retinal displacement with non-drainage? You do not get it with non-drainage scleral buckles. That probably has the lowest risk of retinal displacement. However, when you drain, if you drain in buckles, you will get displacement probably about a quarter of the time. We're still doing studies now, more prospective studies to show that again. We did that in one study, but basically, anytime you try to push fluid, so if you drain fluid, external drainage, there's a chance of getting displacement. If you push fluid with PFCL, for example, and leave PFCL in the eye, you'll get massive displacement. If you use a large gas fill, that'll push fluid and you'll get displacement. So what are the best procedures from a displacement perspective? Non-drainage buccal is the best, then pneumatic retinopexy, and then drainage buccal and pneumatic retinopexy are kind of tied, and vitrectomy is the worst. Vitrectomy, our most recent data shows that it's 100% of vitrectomies have this displacement issue.
But Rajeev, the same concept is there with the steamroll technique?
Yeah, so that's why I was saying the steamroll, when you put a patient face down, you're again displacing fluid and you're moving it. And some of our preliminary data suggests that when you position just to the break, the displacement rate may be less. So in pneumatics, you get displacement as well, 15% of the time for MAC off, 7% overall. And even that we want to reduce further. And so we're doing a randomized trial right now on face down versus position to the break. And we don't have the results yet, but when we did it retrospective, there was a slight advantage for positioning to the break, both in terms of displacement and outer retinal folds. The problem is when you don't steamroll, then it takes longer for the retina to attach. And sometimes maybe for that reason, it might fail because the patient needs to be compliant longer. So we're still figuring out what's better. We know that the displacement rate is less with pneumatic. It's not nil, it's not zero.
Rajeev, the next question is, after injecting the bubble, when you re-examine the patient, how many hours or how many days when you re-examine the patient? Suppose you have injected the bubble, one gas bubble now today, 9 o'clock in the morning. When will you re-examine the patient?
Okay, so there's different answers to this. So first of all, I like to see them the next day because I like to know that they're doing the right positioning, that there's no issue, that it's getting better. One of my colleagues says, sometimes seeing them on day one is discouraging for both the patient and the doctor, because a lot of times you have a lot of displaced fluid. The patient may not have been fully, by the time they got home, they just started positioning. So he actually sees them 2 days later. So I would say 1 to 2 days, depending on how worried you are about their compliance. If you think they don't really understand, it's better to see them sooner. If they're very compliant, maybe 2 days. Now, on the weekend, sometimes like it's a Friday night and I've done a pneumatic, and I won't tell my fellows this, but if it's just me on my own, I can see them on Monday morning. It's probably okay, especially if you trust the patient. So I would say anywhere between 1 to 3 days, but my preference is 1 day most of the time. And then after that, I go based on when it's attached. If it's attached, and once I've lasered the break fully and the fluid's mostly gone, then I'm seeing them a week later. But until the lasers break, until the break has been treated, I'm seeing them every 1 to 2 days.
Thank you. The next question is, if there is a rent in a case and the surgery was done 5 years or 6 years back, whether you will go for this pneumatic retinopexy or not? And if if you'll go, have you ever seen the gas migration in the antechamber?
Yeah, so rent is not a problem. We do it in sulcus IOLs all the time. Even YAG capsulotomy, same type of thing. So we're just careful how we do the tap. So in a patient like that, I'm worried that the IOL could come anteriorly. We don't want vitreous to come forward, all of that. So what we do is we go centrally with the needle, the 30 gauge needle, right in the middle of the pupil and over the IOL in a way. So the needle almost holds back the lens, and a lot of fluid will come out, and you're trying to maintain the stability of the AC. So it's just, you get used to that. But no, a rent is not a contraindication. You know, if there's some vitreous in the AC that prevents an AC tap, I might just inject 0.3 of C3F8 in that case. If it's full of vitreous, then I wouldn't do an AC tap there. I would just inject 0.3 of C3F8, and I would wait it out and let it expand and avoid any anterior chamber treatment, basically, or tap.
So, Dr. Yeah.
Satyen sir, what is your choice of gas?
Yeah, I prefer SF6 because it expands very quickly in 36 hours and it's gone by 12 days. C3F8 takes too long to expand. It takes 4 days and then it lasts for 38 days. These are not favorable parameters. And so I prefer to use SF6 in specific cases like where you can't do an AC tap, where, you know, maybe you really want a very large bubble and you want to put in as much gas as possible for inferior breaks. Maybe in some of those situations. Yesterday, my fellow put in C3F8 because he said a patient was 80 years old, had a big lens, phakic, and he did the AC tap, only could get 0.1 out of the AC. I still would have put in 0.6 SF6, but he was more comfortable putting in 0.4 of C3F8. So he did that.
So Dr. Atul, yes, as we are not doing pneumatic retinopexy cases, as Dr. Rajeev has shown in GRT case also he has done, but usually we do in cases, whatever indication is there, that 1 or 2 break in 90 degree. So that traditionally what we know the criteria. So these cases usually we choose for pneumatic retinopexy. And let me thank Dr. Rajeev to show us that the world of pneumatic retinopexy is far beyond what usually people think. So again, it's congratulations, Dr. Rajeev. You have shown the way that it can be done in more cases. What Dr. Atul, as you have asked, in most of the cases, usually I go for SF6. As Dr. Rajeev has also shown that this case, gas bubble, we do not need once we make a firm adhesion, we do not need the gas. So that period, at least around 10 to 12 hours is sufficient for making this your adhesion of the break. So that is okay. And in almost all the cases, usually I put SF6 because my indication are not that much what Dr. Rajeev is doing. So in these cases, I feel that SF6 is quite okay. And another thing that usually we do cryo. What he has shown, they put the gas after doing the photosynthesis, then the retina gets settled around the break, and they do the laser. So we feel more comfortable. Maybe it's a traditional teaching that we had since our fellowship days. So what we do, cryo first, then we do the photosynthesis and put the gas injection, a single bubble we try to do. But sometimes what happened, even if you are trying in a very expertise way also, it this happens, multiple bubbles. So I think the gentle tapping can help to make it a single bubble. So I think all of you have experienced this, that in out of 10 cases, maybe 6 or 7 cases you make a single bubble, but 3 cases definitely you will have some fish egg sign. That means multiple bubbles will be there. Simple, just tapping the eyeball with your kuchi, that what is called this Johnson pad or that. But you can, yeah, Sourav is laughing because at the
reason I'm laughing is even the phrases.
So kuchi, we used to use kuchi.
Satyen and me were roommates during our fellowship. So what he's speaking, the word kuchi is known to only those who understand Tamil, because Tamil word is cotton tipped applicator is kuchi. So only he can use that
So
word.
I know. Sourav will react on that.
Tightly hold the cotton, that bud like that, and tap
like
it very hard.
No, marble. Have you played the marble? Anybody playing marble?
So that really takes the fish.
So that much of gentle pressure.
Yeah.
So that much of gentle pressure you have to
You'll
put,
put
and
on the eye and then the fish.
So you can make a single bubble. And in my cases, I am happy with pneumoretinopexy, most of the cases. And let me tell something beyond what you have told. I did in some cases, and I presented also some time back, what is called inverted pneumoretinopexy. So someday I will come with those presentations. Maybe that there will be not much scope in this. But anyway, pneumoretinopexy is something great, and I think from Dr. Rajeev's presentation, let us learn that yes, we can do some more with this, rather than going to vitrectomy first. And I tell my patient, suppose it is indicated like you can do pneumo, I tell, let me try non-surgical procedure first. So if it works, fine. You do not have to go for a surgery. So patients are also agree immediately. They'll agree for non-surgical, though they have to go to the OT in our setup, like Dr. Rajeev has done in his OPD setup, but we do in the operation theater. That is not an issue. But these patients, I say that non-surgical procedure will try first. If it is fine, maybe just last week I did a lady who had a superior break, and my colleague saw, he thought this is a long-standing RD. So, but then I saw, no, you can do this with pneumo, you can try, and that lady did fine. This is just 1 week back. So pneumoretinopexy, of course, we can increase the indications now. So I think Rajeev has shown very nicely that even GRT. So Dr. Sourav, what you say, we'll go for this pneumoretinopexy with GRT also. I will try, definitely. Thank you, Rajeev.
Yeah, I think
Sourav sir?
Rajeev was saying something. Rajeev, go ahead. Rajeev, go ahead.
I just want to say, my purpose for showing these crazy GRT cases is not so that, people just start doing them willy-nilly. It's like all of you have so much experience with buckling, especially our older colleagues who, trained at a time when buckling was the main thing. What did our staff do? They could buckle anything they could fix with a buckle, right? And in the same way, when you do thousands of pneumatics, you feel that you can fix anything with a pneumatic. But when you're starting and you want to stick with the routine cases, the simple cases, and my purpose for showing that is that when you see a single horseshoe tear supratemporally, I want you to think like, you can do a pneumatic in a GRT with 10 clock hour tear. And if why should I not try it in this case that has a single break? So that's my purpose, for that, is to give you confidence to try it in the routine cases. And as you do more, after 100 cases, 200 cases, then go for these more challenging ones.
Rajeev, what is your preferred choice? Before gas cryo or after gas laser?
Yeah, that's a great question. So, when we look at this over time, we see that when we do, first of all, laser is a more elegant approach, in my opinion, because it's less inflammatory or less dispersing pigment. It's less, it's just less traumatic to the eye. But what we also notice is that when we do cryo and patient stops positioning, we did some studies looking at how long it takes for the RPE retinal adhesion to occur. It takes about 6-7 days on OCT, whereas with laser, you get some immediate action right away. That's why when you laser a horseshoe tear, usually it doesn't detach. And so what we found is that the immediate adhesion you get with laser is very advantageous in pneumatics, because sometimes 3/4 of the break is attached and the other part's not attached. So then I laser what's attached, and then I adjust the positioning, and I bring them back the next day and I finish it. And with cryo, if it's attached on day 1, they go home and then they stop positioning. They say, oh, it's getting better. The doctor said it's fine. I don't need to position. They stop doing the positioning, and then they come back detached from the same break. With cryo, sometimes you'll see that they'll come back detached from the same break. Whereas with laser, that almost never happens. Once you've lasered the break, it's almost never redetaching from that same break. If it fails, it's because there's another break somewhere that wasn't seen before. So I prefer laser. And so even when I do cryo, because sometimes it's more convenient, you have a pseudophakic detachment, you have the cryo machine right there, and then you don't have to worry about them doing the laser in the next day, 2 or 3. It's more convenient to do cryo. And so you do cryo, or my fellows will do cryo, and then they'll come, and day 5, they'll be attached, and we'll actually add a barricade in the region around the cryo just to supplement it, because I feel more confident that that'll hold. So I think that I don't think there's anything wrong in doing cryo, especially for small pseudophakic breaks that will be hard to see. But for larger breaks that will be easy to see, I prefer laser. And if you do cryo, then feel free to add laser later. And don't laser over the fresh cryo, because that's necrotic tissue. You want to go around, where do very localized cryo and then laser aura to aura in the region of high risk. And, in pseudophakic patients also, and this is how you get your success rates higher, because in the older days, it was like, we position, it's not better on day 2, take them to vitrectomy. But, how we do it is, let's say you have a supratemporal or a temporal detachment in a pseudophakic patient, and we see a couple breaks supratemporally. We know that in these pseudophakic patients, often there's other breaks, right? When you do a vitrectomy, you'll find multiple breaks. And so we'll tamponade the supratemporal break, we'll laser that area, and then there'll be inferior temporal and temporal fluid on the first day. So I'll say to the fellows, okay, now put the patient on their side. Why? Because there's a 30-40% chance that there's other breaks temporally. And then they come back the next day, the whole temporal retina is attached, and we actually barricade laser the whole temporal retina. So, this is kind of a modified, we don't do 360 laser, but we basically do a modified barrage laser in the region of high, based on the configuration of the detachment, you figure out, okay, from 12 to 5 is a high risk area, or 12 to 4, and we'll laser that whole thing, aura to aura. So this is how you can get your success rates up from 60 to 70 to 80 to 85%, and using this. The second tip is use a second gas bubble. Half of the cases that are failing, like imagine you put in a bubble and 2-3 days later, some of your cases are not going to work. Half of those can be salvaged by putting a second gas bubble. So you'll reduce your failure rate by 50% if you put a second bubble and do more positioning in the side. But again, don't be in denial. When it's not working, just go to surgery. By holding on to the patient for weeks is not a good idea. That's when you get the bad outcomes.
Sourav sir, what is your preferred choice?
I think let's stick to whatever he said, and we all agree. 2-3 points that he made, I'll just add on. He said them so nicely and so lucidly to make it easier for the fellows junior people. One, I've seen a few of the chat box questions also. If you can, my first thing is, I don't know how many of you still make the large drawings. When I mean the large drawing, the A4 size paper. If you're doing a pneumatic retinopexy, the fellow or you yourself should have a large drawing. If you're doing VIT, go ahead, do it. I don't care. But if you're doing a pneumatic, each quadrant, each hour should have been seen properly and documented, vessels drawn to the aura, and you should be doing it accurately. You should know by heart we are doing it. So a large drawing for pneumatic is absolutely necessary. One, if you are in little doubt of what Rajeev said about the number of breaks that you might have missed out, with pseudophakic PC on the side, little subluxation, little the eye of the sulcus, not moving, but not very dilated pupil. Maybe in your initial cases, don't do pneumatic in them, shift to VIT in them. And it's in these patients, if you've done pneumatic and by 3 or day 5, you're not convinced it's working, immediately do a vitrectomy. This is my second take-home point. Third, I will insist on what Rajeev said initially about when the retina redirects back, it never goes back to original position. There's a lot of shifting over there. In the last few years, I think as you grow older, you become a little overconfident, a little bossy, you become. I have been doing vitrectomies, a lot of my patients, I leave a lot of fluid behind. I just put a little bit of gas, I do a partial FGE, put a little of gas, I show off a little bit over there to my fellow, see, it'll be okay next day. And it's like, because because at the end of it, you've left so much of fluid inside, like a partial drainage buckle, the retina goes back nice to its original position, and you will have much happier patients. So that's something I will agree with him, because I've been doing this for my VIT patients. So I will totally buy his argument on that. The one point is the intraocular pressure check. I think there were a few questions. I think day 2, day 3, one should an ablation tension check the intraocular pressure, because you may not have a hazy cornea. You can probably have raised intraocular pressure 28, 32 you can have. So do an 80 if it's possible. It'd be a nice thing to do. My last point is, normally I would put a patch on the forehead, arrow facing up. So the people at home should know whatever the positioning is, at any time this arrow should be looking at the roof. So that's one good indicator of the family for the patient to know that they're doing it correctly for positioning. Because Rajeev said that multiple times, call them back, talk to them day 1, day 2. I normally would, if I can, admit the patient and keep them in house and see the next morning again if possible. But day 1 checkup, I think, should be done, if not day 2. That's it. Thank you so much, Rajeev. SF6 for sure. Even macular cases, SF6 for sure.
I agree with a lot of what you said. It's interesting. When you do a vitrectomy, you don't even need to examine the patient properly. You're doing a vitrectomy, pseudophakic, you can figure out everything in the operating room. Why torture the patient with the depressor and everything? So with pneumatic, it's very critical. The most important thing with your fellows, you have to trust their exam. You have to know that they are seeing everything, because if they're not seeing everything, it's not going to work most of the time. So I agree with the large drawings. And I think that's, in the days of buckle and pneumatic, we were much better. And let's be honest, it's harder to do a pneumatic than it is to do a vitrectomy. Vitrectomy is easy. It's the same thing over and over. You mark the break, drain it. No matter how you drain it, laser it, put a full gas bubble, it's going to attach most of the time. So, but we have to start going back to thinking about what we're doing. And now we have this integrity data. We know that if you just force things attached, it's not the best for the patient. And it goes back to requiring skill. And that's a good thing. We want to have our fellows trained to be very thorough, to find every break, and to think about how they're attaching the retina and not just repeating some procedure over and over again. So I agree with that. Intraocular pressure, I don't check it on the day of the procedure, but I do check it every other visit when they come in. Yeah, I agree with a lot of the other comments you made.
Also, Dr. Sourav, what you have mentioned, that positioning, the patient should realize that importance of positioning, because pneumoretinopexy itself, it's a game, it's a
Oh, you muted yourself, sir.
Sir, you are muted.
Importance of their positioning. So let me give an example. My patient, what I did last week. First day, patient was not that much, not that serious. So what happened next day when we saw there's some fluid, then we realized that yes, you have to be more serious. And by next checkup, everything was flat because patient could maintain the position. And of course, it was not exactly at 12 o'clock, maybe around 10:30 position. Sometimes no patient feel how I can keep this position, and this arrow for the family members is the indicator. You have to be in position. So I think that is a good idea to mark the arrow so that everybody knows this person has to be in this position at his family. And that is only for the week or 10 days. So this positioning, we have to give the importance so that patient and their family knows that positioning is having the primary role in this pneumoretinopexy.
Dr. Rohan,
Dr. Rohan, what is your preferred choice of gas?
First of all, I would like to congratulate Dr. Rajeev for such an excellent talk and such excellent results that you have got. Many of your cases, definitely, I would have done a buccal or a vitrectomy and not a pneumatic, though I have been doing few pneumatics, not that many. Regarding gas, I think major thing which I've learned from your talk, what I have been doing is we have been using C3F8 for the primary reason that you have to inject less, and we have been worried about the IOP. Despite a paracentesis, I would say in my cases, the IOP would go high. But from what I learned from your talk is how to do a paracentesis. So that's, I think, a technique which is worth learning. And we have never been doing that much of pressure on the eye and taking out so much of fluid. Because we just take out about the 0.2 ml, then you cannot inject more than 0.3 cc C3F8. If you go to 0.5 cc SF6 and do not take out much, it's definitely going to cause an IOP problem. So I think that is one major thing differently which you are doing from what we have been doing, which needs to be done. And then yes, change over to SF6. And probably why we have been using C3F8, maybe we have also got secondary inferior breaks because the gas has been staying long. I don't know what's your view on that. Have you experienced secondary inferior breaks in any of your cases? You're mute, Dr. Rajeev.
Yeah, I'd like to discuss the two issues. You know, the intraocular pressure rise, and you know, I can confidently say we've done thousands and thousands of these pneumatics now. The pressure, 100%, when you inject the gas, the pressure is 80 millimeters of mercury right away. So first of all, we remove as much as we can, but even if I take out 0.2, I'm still injecting 0.6. I'm never injecting less than 0.6, but I'm retapping after. So as soon as the gas goes in, they're usually NLP, but within 2 or 3 minutes, I put them face down, and that will allow the fluid to go into the anterior chamber, because what happens is the gas goes to the back and all the liquefied vitreous will refill the AC very quickly. And then we do a retap. And when you do the retap, all of our patients, by the time they leave, they have normal perfusion of the optic nerve. And on day one, they never have high pressure. Maybe 1 out of a couple hundred will need a glaucoma drop. It's very rare. So I think it's a comfort, you know, like, you know, when you're doing this over and over again, you see what happens. So I think that what I would suggest is, if you're concerned, if you inject less gas with SF6, you inject less gas with SF6, the success rates will go down. So that's why we like SF6. C3F8, I think if you're worried about the pressure and you're more comfortable, then there's no harm in doing that. I think you go with C3F8. But I think that the pressure issue is more of a comfort thing over time. And the second thing you talked about is the inferior breaks with traction. You know, now we have the Optos wide field OCT, and we're actually imaging this areas of traction, inferior vitreous pulling on the retina. And before the bubble's put in, even there's some traction, and then you put the bubble in and we monitor it. There's no change. You know, this is also a theoretical concern that the vitreous, when the bubble goes up, it drags the vitreous, and then that causes a break inferiorly. Number one, we always laser any lattice beforehand, and we follow these patients every time. We examine them very thoroughly. The majority of the time when a pneumatic fails, I believe that it's due to not a new break, but an unseen break. Pseudophakic patients, we go in, they fail, we go in, we do our inferior vitrectomy, and we find, oh, there's a little horseshoe tear at 5 o'clock or 5:30. It's very rare, like for example, in a phakic vitreous filled eye, that a brand new large horseshoe tear or something will happen inferior. That's not a common occurrence also. So I think it's a theoretical risk, and I do think that you should examine very thoroughly at every visit to make sure that there's no early pathology that you can treat with laser. But in practicality, we're not seeing a lot of cases like that where you're getting a new horseshoe tear. But very important points. I think from a safety perspective, you want to monitor, make sure that you don't have any IOP issues, and make sure that you're not, you know, if there's new pathology, that you're addressing it.
Actually,
Dr.
most of
Rohan.
the cases that we are doing in the OR, even the pneumatic retinopexy. Okay. So I think there we have a position, you cannot again make the patient face down and do a retap. The patient is always going to be lying supine till the end of the procedure. He's fully draped and covered, so that we cannot do probably.
Yeah, so if you don't put them supine, you can still, if you wait 5-10 minutes, it'll reform.
Yeah, we'll probably wait.
Do it again. Yeah, that would
Sorry. And the other important thing which I learned from your talk is that post gas, when you are doing the laser, don't just laser the break, but laser all the suspicious areas and cover up till the aura. So I think that's probably also helpful in covering any thing which you may later on be calling a secondary break.
Yeah, I think that we like doing extra laser. Like, you know, some of we'll see 4 or 5 rows, especially the anterior horns of the tear, you know, so I think that laser is definitely your friend in pneumatics, and a little bit more is I think always err on the side of putting more laser than less laser. The one thing you want to be careful about is you don't want to laser over fluid. So don't kid yourself and think it's attached, but then it's actually, there's fluid there, and then you're hammering high power laser, and you can make holes with the laser when there's fluid, when the retina is detached. So you can indent, and if it's a little bit moist, you can still get good uptake, it's fine. But don't persist when there's like a bullous, or not bullous, but like sometimes you can't see very well after the bubble's gone, and you think, and the uptake's not there, and then you depress and you realize, oh yeah, there's still fluid. So then give it a day and then come back. Don't especially inferiorly and that kind of thing. That's another way to get in trouble, is if you it's actually detached and you're applying strong laser inferior, and then you can run into some problems.
Thank you. Very nice points.
Dr. Rohan, one question I got that can we decrease the IOP by injecting the mannitol 1.5 hours before doing the pneumatic retinopexy? Or by giving 2 Dimox?
We were actually injecting mannitol, but like I saw in his cases, he's never done that. So probably that's not required. So just the good amount of paracentesis, and maybe yes, you can use acetazolamide after the procedure.
Yeah, just
No,
it's a
sorry, I'll just butter over here. That's why my finger continuously. Acetazolamide 2 tablets before the procedure is not a bad idea. You can sort of, just have 1 hour for the procedure, not mannitol, but 2 Dimox pre-procedure is also pretty good idea.
Just from a historical perspective, I was talking to Ingrid Kriesig, and she was the first one who started injecting expansile gas in a vitreous-filled eye in 1970s. And she used a Honan balloon for 30 minutes. Then she put in 0.4 of SF6. Then she put the balloon on a second time and injected again a couple times the gas. So this is an old approach also.
It makes good sense actually.
Rajeev, which syringe you are using and which needle you are using for this pneumoretinopexy?
Yeah, I like a TB syringe, 1 cc syringe with 30 gauge needle for an inferiorly over iris for the AC tap. And you saw how much pressure I was putting. And then for the injection of gas, a 3 cc syringe. If you use a 1 cc, it's much longer, and so it's hard to control. And so if you have a 3 cc syringe with 30 gauge, it's perfect length that you can go in halfway, pull back, and still inject and be in control, because the control is important so you don't get fish eggs. If you're not in control there, you're going to get lots of bubbles.
So one more question, Rajeev, how you are keeping it ensure that you are not in the anti-highlight phase, because you are not able to see the tip of the needle?
Yes, so there's this theoretical risk of gas bubble in the anterior hyaloid space, in the space of petite, and you get this sausage-shaped bubble. It's very, very rare. 1 in 1,000 cases, I would think, is happening. Almost never. It's if it happens, you go face down, and usually the gas, as it expands, breaks through the anterior hyaloid face and goes back. So yes, you have this theoretical risk, but it's not a practically, it's not a problem.
Okay, and would be like, what are the cases in which you will avoid pneumatic retinopexy?
Okay, so this is a great question. First of all, if I have subretinal gas, maybe 1 in 500, you get a large amount of subretinal gas. If you have a small bubble away from the break, it's not a problem. If you have a bubble that's going underneath the break constantly, and that's preventing closure from the break, I'm very quick to abort. There was a case that was posted where someone waited longer. I prefer to go in earlier in those cases. And you have to be careful how you take that gas out. If you make a hole to take the gas, you're going to get that giant tear, because the gas stretches the retina. So even if you make a small break in there to get the gas out, it can make a large tear. So you have to be very delicate with the back flush cannula, whatever, and slowly take the gas out. Sometimes you can put a needle from external and get the gas out there, at the time of vitrectomy, because it can be very high, the gas, against the back of the lens, so you don't want to mess with the lens either. So that's one case. Second case, is when you have vitreous hemorrhage that has gotten worse after the procedure, or it's been moved around. So if there's mild VH inferiorly, and I can't examine, let's say 5 to 7, but I know there's a single break up top, the configuration fits, I'll do a pneumatic. But afterwards, if the retina, I can't see, I can't examine it, and I think it's not working, I'm going to abort very quickly, because you don't want to have a detached retina with hemorrhage. That's the setting for PVR. Those are 2 scenarios. 3, basically when it's not working, if I have a 6 o'clock break, when I have a 6 o'clock horseshoe tear, I generally don't do a pneumatic. But Dr. I think it was Dr. Sinha was talking about leaving fluid. We're also developing more of these types of procedures, like something we call minimal gas vitrectomy, which I think is very similar to what you're doing. Basically, we're doing a full vitrectomy in certain cases. Let's say you have a dense VH, okay? So I can't do a pneumatic. I'll do a full vitrectomy, and I say, oh, there's only a single break at 10 o'clock. So then what I'll do after my vitrectomy, I'll cryo that break, I'll close all the ports, and I won't do any drainage. I won't do any other pexy, I'll just, other than the cryo. And then I'll do a pneumatic on the table. I'll take out 0.3 of SC3, 0.3 AC, inject 0.6 SF6. Patient does the same positioning that they would do with a pneumatic, and you'll get the same outcome. Similar, you'll minimize displacement, you'll minimize outer retinal folds, this ellipsoid zone loss, all of these things will be very minimized. And so you can take the concepts and apply that to vitrectomy. Also, you can apply it to buccal. When you do drainage, you are going to displace the retina. So don't drain if you don't have to drain. But that said, in some cases, we have to drain. So, but I think the main point for all the fellows and our younger colleagues here also is don't just do a vitrectomy and not think. Think about what you're doing. Think about the case. Think about where the tears are. And how can you attach this retina in the most gentle manner possible, whether you do buccal, vitrectomy, or pneumatic?
Rajeev, one more question I got on the WhatsApp. Our doctor was doing this pneumatic retinopexy, and on the next day, he has seen the IOL drop was there, and the eye was in the hypotony. What can be the reason for that?
Yeah, I mean, I think when a patient is elderly, if they have a zonular issue, perhaps that could have been one thing. I haven't seen that happen myself, where an IOL, I've seen it after vitrectomy, but not with pneumatic, but it could happen. I mean, what I would say in that situation is try to treat the detachment, focus on the detachment. Don't worry about the lens. We know that the lens is not really going to cause any issue right away. If, for example, you had just a 12 o'clock break, I would still position up top, I would do the laser, and then I would go in and when I have time, I would fix the lens. If the retina doesn't attach, or there's other pathology, it's not going well, I would just abort the pneumatic and I would go to the operating room. I would, do everything in one session there. Maybe take out the lens and come back later and just fix the detachment.
Okay. One more thing is, Rajeev, you told that if some pathology is there in the attached retina, you do the laser around that pathology and you will go with the normal PNR procedure. Suppose there is a bullous RD in the superior area and inferiorly one large HSP is there. You have done the laser and you have put the SF6 gas. If this fluid will go down, how much chances are there that it can open up that break?
That's a great question. This is where you start to get into advanced techniques. So if we have a 6 o'clock break and a supratemporal detachment, if you just put the patient to the break, that fluid is going down to 6 and your pneumatic's automatically going to fail and you're going to go to the OR. So we laser the break, good 3-4 rows. Then there's actually a way to position the patient you can make fluid go counterclockwise or clockwise depending on how you position them. So in that situation, actually what we would do is first we would put the patient on their side on a decline, and then we would steamroll them, but on their side, we're gradually raising their head. And what's going to happen is the bubble's going to push the fluid, and then the next day you'll have the residual fluid will have gone nasal, the opposite direction, and we can avoid that from happening. So this is a more complex, and you have to get a really compliant patient. Now, sometimes, let's say even you don't do that, the laser will hold. And just because you have a hole, let's say you have a lattice with a 6 o'clock hole, just because there's a hole, don't assume that it's recruiting fluid. So on day one, you could have displaced fluid into the lattice with the hole down below. You laser your superior brake, and over the next few days, it'll reattach, because every hole is not allowing fluid to get in enough that it's going to compromise the pneumatic. But that said, when pneumatic does fail, the majority of the time, I believe it's unseen brakes or brakes down below that were there, and that's why if there's ever a brake above 9 and 3, almost always you can tamponade and laser. So I think that when it's failing, you have to be very suspicious that there's an inferior brake, and that you then go on to surgery. But you can steamroll to avoid that. Make sure you apply lots of laser. And don't assume that a lattice with an inferior atrophic hole is actually recruiting fluid. It may not be. So the key is, with fluid, that every day you say to yourself, is the fluid better? Is it worse? Or is it the same? If it's the same or better, you don't do anything. If it's getting worse,
Rajeev, can you hear me?
Yeah, yes. If it's getting worse, then there's an open break. And so one of the mistakes early in your practice is you've done a pneumatic, the brake's been treated, and you have this residual fluid inferiorly. And you say, oh, there's a lot of fluid, I'm going to take them to vitrectomy. But now what are you going to do? There's no open break. So you have to make an inferior retinotomy. And sometimes even that old thick fluid, it's hard to get out, even at vitrectomy sometimes. And so then now you have residual fluid inferiorly, you've created an inferior break. Now you're going to put in silicone oil. So don't go in prematurely when it's actually working. That's another thing that you learn over time.
Dr. Rajeev, please share the case, like what are the complications you have seen with pneumatics? I
mean, when you do lots of them, you've seen everything. So I've seen, what are some of the things that have happened? You've had patients who I've had the lens has been touched during the anterior chamber tap. That's probably the worst thing, like as a retinal surgeon, the last thing you want to do is deal with the lens, right? So and everyone can see the lens too. So you don't want retina, I can fix anything, but in terms of don't touch the lens, I tell the fellows, no matter what you do, just don't touch the lens. So that's the one thing, I think that early on, the fellows get a little nervous with the tap and, how we do so much fluid out, and then we do the retap. If they're just going in not careful, they can touch the lens and puncture the anterior capsule. I remember when I was a resident, I learned to do it in my first 5 cases. My staff made me do the pneumatic with a 25 gauge needle right in the middle. And that's how he did it. He said, don't worry. And I touched the lens. So ever since then, I go inferiorly over iris with a 30 gauge needle. Other things, regular things can happen. Patients can get macular holes. The ERM has been mentioned. Subretinal gas. I told you that example early in my career. I got a case who had a large subretinal gas, and I went in and I was having trouble because the retina was against the lens basically, and I couldn't get the gas out. I didn't think of going from the outside, which I should have done. So I made a little hole with the vitrector, and I thought, okay, I'll just suck it out from there. But as soon as I touched it with the vitrector, a huge tear occurred, radial tear. And so I'm very careful if I get subretinal gas about doing that, because you see the retina is actually very, very stretched under that bubble. So if you even make a small hole, it'll become big. Other than that, I think it's just cases that have failed. The odd patient you'll do a pneumatic and they won't show up again, and they'll come back at a month, and now you lost your opportunity to treat them, and they have a chronic detachment with PVR. So anything can happen. It's all about conscientious care and follow up, and you believing that what you're doing is the best for the patient and following them appropriately. I think this is really important.
Yeah. Dr. Kaushik?
Yes, Dr. Atul.
Any other questions?
I think we have a few questions in the chat box which have not been discussed, like how do you laser the like anterior flap of the GRT when you did this pneumatic retinopexy?
No, it's just the posterior aspect. And, just a story, like in our fellowship, it's a rite of passage to get through the St. Michael's Hospital Fellowship. You have to do one pneumatic GRT. And so every fellow is looking for this case. And the lasers, can be challenging, but we don't laser the anterior flap. We're just lasering the posterior aspect of the brake. And one of the beauties of pneumatics with GRT is often the GRT, the anterior and the horns on the sides are usually attached, right? It's the retina's flapped over. Now, if the retina's tacoed over, I don't do a pneumatic. You can't, because you need some space there to get the bubble in. We'll often laser the horns before the gas bubble goes in. And then when we put the patient face down, often within a day, the retina is fully attached because, again, the buoyant force of the bubble pushes fluid out through the brake very quickly because it's so large. And then it takes a couple days to usually get the laser done. But it's a very beautiful thing when it works. So when you've done a few and you're confident, I highly recommend trying it in these cases.
What is the concentration of gas and how much do you inject in the second time?
100% SF6, 0.6 each time. The second procedure is a direct repeat of the first procedure. I don't change anything, except I'm injecting into the bubble. So I make sure that the patient moves their eye in a certain way so the bubble is there and I inject into that bubble.
Does the position of the brake or retinal detachment change the position where you are injecting?
Yes. So if there's a very large supratemporal gaping hole, I'm not going to inject there because as you inject, the gas is going to come up to where the brake is. So if you got fish eggs by chance, you're going to go subretinal. So if the retina has a very large brake, I'm going to go in the opposite quadrant. So if it's supratemporal, I'll go supranasal. Supranasal, I'll go supratemporal. I never inject inferiorly because I think you're going to increase your risk of fish eggs. And then if it's very, very bullous, even then it doesn't affect me too much. But if it's really bullous, then you might want to go in the opposite quadrant. But again, you're going through the pars plana, so it shouldn't be a problem.
What do you use for laser, like indirect or slit lamp?
100% indirect. I know some people use slit lamp and only have access to slit lamp, but I very, very, very highly recommend using indirect laser. A 28 diopter lens is my favorite. You get a very nice view, peripheral view, and when you get confident and comfortable, the laser doesn't take more than 5 or 10 minutes. Sometimes my fellows go in and they come out and they're sweating. They have the red band on their head. 30 minutes later, but this is experience. With experience, you get really good at it. So it's one of those things that there's a steep learning curve, but after a little while, it gets very easy.
How do you define a failed pneumatic retinopexy and you plan to proceed for PPV?
Failed pneumatic means that there's an open brake that's recruiting fluid, that the fluid is getting worse. So that's that key. Is it getting better? Is it the same or is it getting worse? If it's better or the same, you have time. If it's progressing, so initially it might have improved because you did face down, but then you're seeing them and it's getting worse. I don't like to sit on these. And that's the other thing. To get good outcomes, when pneumatics failing, I would say if it's a fovea off, within 3 days. I'm not waiting a week. Like if it's Friday and I'm not operating till the next Friday, I give it to one of my colleagues. I won't, I'm not going to make the patient wait for 7 days and make them face down or something like that, because I think that's when you can get bad outcomes. So I like to do the surgery for a failed pneumatic within 3 days. If you can't do it, then give it to one of your colleagues.
Now, how do you decide whether to repeat pneumatic or do a PPV?
Good question. If the brake, so if I did a pneumatic and let's say it was a 12 o'clock break and they came in with a new detachment, it's a 10 o'clock break, I'm doing a pneumatic. It's all about brake location. I'm treating the brake. If I can treat it with a pneumatic, I'll repeat the pneumatic. If the patient has an inferior brake, if they were very non-compliant, if the patient's getting frustrated, then I go to surgery, so you have to gauge it based on the patient, but I'm really going based on the brake. So we do a lot of second pneumatics. What I mean by that is like we do planned second bubbles. So I don't consider that a failed case. But let's say that you have a patient who comes back a month later with a new brake, then I have no hesitation to repeat.
Okay, and you have already told you laser when there is gas. Gas bubble is there. Yes,
Yeah,
that was-
I laser through the gas bubble, and I laser, there's two ways you can move the head and move the bubble away and laser it, or you can keep the bubble. And I prefer to go through the bubble because the bubble minifies your view, and you can laser 4 or 5 clock hours with almost very minimal head movement. And one trick is when you have a pseudophakic detachment, pseudophakic patient, if you lie them on their back, just looking straight to the ceiling, and you look in, you almost get a panoramic view. You can almost see 6, 7 clock hours all in one time. And you just, very quickly can laser almost like 180 degrees.
How many patients developed cataract in your series?
So in the pivot trial, 65% of phakic patients got a cataract with vitrectomy over 1 year, and 13% of pneumatic cases got vitrectomy. These are like regular nuclear sclerotic cataracts. The risk of a cataract due to the procedure is very negligible. I mean, it's mostly inexperience. When you're early in your training, you can do it because you're just not comfortable with the eye as much. And so I think it's all technical. That's something, once you're good at it, it's almost very, very rare.
I think you have already discussed like when you examine the patient after injecting gas, that has already been taken care of. And there is one question: do you think Caucasian eyes with less pigmentation has less PVR compared to Indian eyes in case of failure?
Yeah, I've been saying this. In Canada is a very multicultural country. Like the number of Caucasians that is maybe a third or maybe half of my patients. But yeah, there's no difference. Caucasian or Indian patients, it's all the same. Maybe the odd patient who has had albinism or something like that, you have to be cautious and make sure you get enough laser there and heavy laser sometimes to get uptake. But other than that, it's not an issue.
If during pneumatic retinopexy there was previously posterior capsular rupture and bubble comes in the AC, how do you manage?
Yeah, that's a great question. So again, this is where you get some experience. What I would do, I don't try to take out the gas on the same day. I just go ahead, because even if I inject 0.6 and 0.2 came into the AC, the rest is in the back and I can still get it out. I can still use that to attach the retina. Then what I do on day one, because it's very hard to laser when you have gas in the AC. So what I do is I don't dilate their pupil. I bring them in, I sit them upright, and I go with a TB syringe, a 30 gauge needle, and I aspirate the gas superiorly while they're sitting up. So while they're sitting up, the gas will come out. The gas that's in the back will not come forward. If you lie them on their back and you take out the gas, more gas will come forward. So keep them upright with a small pupil and very slowly take out. And don't go for every last drop, because you want the needle only in the bubble. If you go into the fluid, you're going to decompress the AC and you're going to get maybe more gas coming. So keep the AC formed and only go in the bubble and take it out until that last little bubble is there, and leave that little bubble, and that'll go away in a day or so. And then you can do your laser. In aphakic patients, I always cryo, because in aphakic patients, very hard, because when you lie them on their back, the gas just peeks into the pupil and you're gonna not be able to do the laser. So I like cryo in aphakic patients.
Is volume of gas injected different for each size of RD?
Sorry?
There is a question, does the size of volume of the gas change on the size of RD?
So I used to inject as much gas as possible. The way that I do the tap, sometimes I could get out 0.7 cc's, and I would add 0.3 to that. So I would inject 1 cc, but never less than 0.6. I'm not doing it based on the size of the detachment. I'm doing it based on the location of the breaks. If I have a breaks, 3-4 breaks, all temporal from 5 to or let's say from 1 to 5, I need a bigger gas bubble. So I'm planning to do a second gas bubble. But in those cases, I'll try to get as much fluid out as I can. And sometimes I'll inject 0.7, 0.8 cc's. Whatever you remove from the AC, you add 0.3. That's the golden rule, and never less than 0.6. Those are the two tricks for that. And then don't hesitate to put a second bubble in on day 2 or day 3.
How many of your patients complain of floaters, increased floaters?
Yeah, that's a great question. Everyone complains of floaters early on. But like a PVD, it almost always goes away, the symptoms. Patients stop complaining about it. I would say in pivot trial, we had 1 or 2 patients we'd had to do a vitrectomy for. And the odd patient, maybe 1 in 100, I'll do a vitrectomy and remove the floaters. But it's a very easy procedure, you know, just in and out, much simpler.
I think you have already answered this. In GRT cases, vitreous extraction exists at horn. How good is pneumatic retinopexy in holding GRT cases in your experience? How many cases have you done of GRT with RT?
GRT, how many we have here? Approximately 30 cases. 30 cases.
And there was around 60% success.
67%, 2/3.
7%.
Yeah, 32 cases, 31 cases, 2/3 avoided OR.
What is your experience with 100% 60 effect?
Yeah, it's not my preference because it lasts too long and it takes 4 days to reach its maximal size. But there's many very ardent supporters of C3F8. So I think it's that's a surgeon preference, you know. I think it's okay. But I prefer SF6. I think the ideal gas is SF6.
Then do you have a preferred quadrant for injection?
Away from large breaks.
Okay.
Whether you're going, Rajeev, if the RD is very large and bullous, anytime you're going through the RD also.
Yeah, you have to, you want to be careful not to bury your needle in those situations and try to go in the quadrant away from if it's very, very bullous against the lens. But even most bullous detachments, you're injecting through the pars plana, so it shouldn't be a problem. Same thing when you put in your trocars, you know, it's not usually an issue.
And
Rajeev,
yes, Doctor.
Dr. Wong is asking, because it is a little blind procedure, have you ever injected the gas in suprachoroidal space?
So now I'm trying to figure out how to do that on purpose. That's what we're trying to do now, because for inferior breaks, I want to inject suprachoroidal gas or viscoelastic to try to treat inferior breaks. So I can do pneumatics for inferior breaks. I can use the visco suprachoroidal for the inferior break, like a temporary buckle, and then do a pneumatic. But when my fellow does it, most of the time, it's funny, it's like a temporary buckle. It doesn't cause any problem. You know, the patient has a little bit of pain when the gas goes in, but it has happened. I've seen it maybe 4 or 5 times in my 10 years of practice, and it hasn't caused any issue. It makes the laser a little bit difficult because often the tear is at the edge of the choroidal. But usually we can get the laser done. But yeah, it's important to, when you pull back, you know, you want about 1 millimeter of the needle in, but it is a blind procedure, so that risk is there.
If the retina has attached and you have lasered the brakes, and do you need positioning after that also? After pneumatic retinopexy, retina has attached and you have lasered all the brakes.
Yeah, I prefer to. I'm more strict on compliance, so I ask them to position until the bubble's gone. But many people will stop after 5 days, and usually it's fine. But you know, sometimes I'm lasering more clock hours. Like the brake is lasered, they still have temporal fluid. I'll put them on their side. Then I'll laser a few more clock hours, especially in pseudophakic patients. It's like it's buying insurance, you know, against a failure. So these little things will make your success rates higher, you know, from 70% to 80, 85, you know, so I like that.
How do you keep your neck healthy? There is a question like you are doing so many laser procedures and indirect procedures.
Get young fellows.
Rajeev, one question is, what should be my ideal first PNR case? This is from a very young surgeon.
So I would go with a single break, supratemporally, supranasal, single break. Those are home run detachments. Almost 95% of the time it's going to work. So, and feel free on the chat. You know, the chat has been an amazing resource, and I'm involved in many chats, almost like 2,000-3,000 people, and everyone's starting to do these. And feel free to, you know, there's so many people who have done so many, and it's not most of the time when I'm teaching my fellows, it's over the phone. They're texting me, they're saying, this is what's going on. You have to trust their exam. That's the key. After that, it's all technical and you can talk someone through it. So post and people will give you advice, what to do and, when it's failing, when it's not working. So yeah, our world has changed everything. It's great to have this kind of resource.
Just one comment.
And I was joking about the neck thing. I think it's very important. I shouldn't minimize it. Like all of us retinal surgeons have back problems and neck problems, so we have to be very mindful of that. I think as you get more comfortable, you don't spend so long doing the laser. When you're young, and I've done it myself. I've done like 30-minute indirect sessions, and your back's hurting. And now as a staff, it's not. I'm just more efficient, and I'm more careful with my positioning, the way I'm not slouching as much over like during the treatments, those types of things.
Yeah. So now just for the person doing the first pneumatic or the second one, 2 points that Rajeev made. One was I have very small hands, so I use a 2cc syringe. So you have to customize things for yourself. Not use a typical syringe while injecting. It's very ungainly, doesn't fit our hands usually. So 2cc syringe, he recommended 3cc. My second point is, don't be too gentle in injecting your gas. If you do it very slowly, you're having fishing. So it has to be a little swift injection when you're pushing when you're injecting a bubble in. You don't worry about going in all the way. It won't happen. You can't be so damaging. So 2 points. One, use the syringe. Make sure you do dry runs. You know what you're doing before outside the eye. Some air, do it with your hand. And I've always told this, that even those two of my medical retina fellows, I make them give the first intravitreal injections on eyes who had a block, just to get the idea of the feel of it. So those of you who are not sure, in eyes which are blocked to vitrectomy surgery, practice this injection giving in a patient lying over there. Or before you give you a block, practice this over there. An eye you're showing how to give vitrectomy, practice pneumatic in the patient before giving the block. Practice the AC tap in an eye which is moving around before doing the vitrectomy. So you've got confidence doing these procedures. I think it's very important.
Also for those who are just starting and going to start from fresh, we're doing research now on implementation of this procedure in new places where they weren't doing before. And so please reach out to me, because we're trying to keep track of these cases and see how the uptake is and how, people go through the learning curve and things we can learn. And, as Dr. Sinha mentioned just now, like all these little tips for your first cases, that will be helpful.
So we have another question. Do you think volume of gas would make a difference in very high myopic eyes?
I think in those large cases, you want to inject as much gas as you can. If the breaks, you need to cover large areas. But no, I think in high myopic eyes, the gas wall is going to cover a smaller arc, right? And so if you need to cover a larger space, you might need more gas. But the good thing is in those myopes, they have very liquefied vitreous and they have a deep AC. So I've had myopes where I've taken out 1 cc out of the aqueous and I've put in 1.3 of SF6. So I can usually get a bigger bubble because I get more fluid out and there's more space in a way. Yeah.
Does gas injection accelerate posterior vitreous detachment?
Yeah, I think we are doing research on this. I think it does accelerate PVD formation. One of our research fellows, Isabella, is working on this. And, what would you say? Within a month, almost everyone if the hyaloid is attached, within 1 month, it detaches. So in patients who don't have a PVD, it was never a criteria in pneumatics to do it with PVD or no PVD. Always just do it. But in those cases that don't have a PVD, I might now start thinking about monitoring them a little bit more carefully, like in the first month, because usually they'll get a PVD.
Dr. Kaushik? No more question from my side.
I think it was yes.
Yeah, my quota is over. I was just telling.
I think it was an excellent session, and I must thank Dr. Rajeev Muni for increasing our confidence on pneumatic retinopexy. And actually in India, it is very difficult to do multiple surgeries if they are needed, specifically in the private practice. So I think we can try, we can select cases which actually there are like selections. We can actually in private practice, strictly speaking, I have not done a pneumatic retinopexy till now. Though we had done in institutes, so I have not done. I think I am getting confidence to select few cases and start one or two and see how, because obviously.
Sorry, one last comment I'll say. You know who the ideal candidate is that 50-year-old engineering person who's going to come in and who has like a max split detachment, superior break, single break. Those patients, when you do a vitrectomy, they're going to complain about anisoconia, metamorphopsia, this and that. And so those are the ones where it's most, I think, beneficial, like an easy detachment, a young compliant patient with a single break. Those you can really tell them that their outcome will be better, vision wise.
I'll thank Dr. Satyen Deka sir, Dr. Sourav Sinha sir, and Dr. Rohan Chawla sir. They have been our teachers and they have huge experience in treating retinal disorders, and it was our privilege to have them and hear them talk. And I thank Dr. Nitesh Salunke and Dr. Atul Dhawan. This international program is a brainchild of Dr. Atul Dhawan, and I sincerely thank him. And I'll invite you to our next All You Need to Know series classes. The first one will be taken by Dr. Pramod Bhende sir on diabetic vitrectomy. This class will discuss diabetic vitrectomy in detail from for a beginner to advanced surgeries. It will happen online on 30th January, 9 p.m.
One second. It's 8 to 9.
Yes, 8 to 9. Sorry, 8 p.m. With your permission, sir, can we close?
Yes. Okay.
Thank you very much. Thank you. It was really a great session.
Everyone.
Yeah, thank you, Dr. Rajeev, and thank you, ASG. Thank you very much.
Thank you,
everyone. Thank you, Rajeev. Thank you, Satyen sir. Thank you, Sourav sir. Thank you, Dr. Rohan, for joining us in this program.
Okay.
And
thank you everyone for a wonderful talk.
Academic cell, Dr. Ganesh and Dr. Mayank Sarma.
Thank you, Dr. Atul and Kaushik. Thank you.
See you on 30th then again. Thank you so much.